All right. Jonathan and David, can you see that okay? This screen slide?
Yes.
Great. Well, welcome everybody. Pleased to welcome all of you to the Leading Voices in Public Health lecture. This is the first Leading Voices lecture for the 2021 academic year. For those of you that are new to the process, 14 years to address topics of important and more important, more timely than the one we're dealing with tonight, which is coronavirus, separating fact from fiction. I'll introduce our speakers in a moment. I'm joined by Jonathan Moorman and David Kursky. We'll start with some brief introductions, and I'm going to do a quick overview of the global pandemic. Dr. Moorman will follow with an overview of the virus, and Dr. Kursky will overview of the pandemic, and then we'll try to answer as many questions that you have and have submitted that we can. There were many more questions that came in than we can possibly deal with in the time that we have, but we have combined them into clusters and ideas, and I've shared them with the speakers in advance so that many of your issues will be addressed. I'm Randy Wykoff, the Dean of the College of Public Health, joined by Dr. Jonathan Moorman, Professor and Division Chair, Director of the Center for Infectious, Inflammatory, and Immunologic Disease, Quillen College of Medicine, and Dr. David Kursky, Health Officer for the Northeast Regional Health Office and a former EIS officer. Please, everyone, be reminded this event is being recorded so that you can watch it later and also share it with your friends and colleagues. So I'm going to start with a quick, oh, and let me add, everyone is muted. You cannot unmute yourself. You can ask questions in the chat room, and we'll be monitoring that periodically. All right, so the pandemic begins in late 2019, probably in November in China. Shortly after it was reported, it has spread rapidly throughout the world. Europe was heavily impacted early on, followed by North America, and now appearing to the disease to be impacted mostly, or more heavily in South America. Dr. Moorman will talk about the virus known as SARS-CoV-2. So by early March, there had been 10,000 deaths in the world. That's when most of us became aware of this pandemic. 10,000 deaths, reached 100,000 in less than a month. 500,000 in a couple of months after that. And it's been growing inexorably around the world ever since, passing 1 million earlier this month. And of last Thursday, that's where we were. As of 5 p.m. this evening, there have been 44 million reported cases worldwide and 1.1 million deaths. Now that pattern is the world overall, but it's important to understand that the pandemic is spreading at different times in different places. So we have countries in Europe, Belgium, France, and so on that saw a very rapid rise early on, and then have seen relatively little change in their death rate until recently. Conversely, the United States has grown a little more slowly, but more consistently. There are countries like South Africa that grew quickly and now seem to be slowing down, and then countries like India where the death rate is still going up. So if you look at a map of the world, in January, it started in China, spread to Europe, then North America, and by April was pretty much everywhere in the world. This is a chart that shows the number of deaths per day, and the color coding, you've got China there in purple, so early on that's where all of the deaths were. Then it became largely a European phenomenon in March and April. And then over the course of the summer, largely North America. But now we're keeping our eye on this resurgence of deaths in Europe. We don't know if that's because they're opening up or whether because the virus has mutated in some way or whether it's just an anomaly of this particular disease. But that's something we're keeping an eye on. In terms of how bad this is, it is important to point out, if you look at the 25 worst pandemics in recorded human history, COVID-19 is already in the top 20 with over 1 million deaths. Now, you know, the world population changes a lot, has changed a lot, but nonetheless, this just tells you that this is an important pandemic. It's a major cause of death worldwide. In terms of the US, The first cases were probably in late January, early February. By early March, we'd had 12 reported deaths. We got up to about 36,000 by mid-April. And the reason I point that out is that's the average number of deaths we would have in a year from the normal influenza. It's been growing. By May, we hit 100,000. And it's continued to grow. Such that by 5 p.m. this evening, we've had 231,000 deaths in the US, 9 million confirmed cases, and about 6,000 deaths just in the past week. The US accounts for about 1/5 of all the reported cases and all the reported deaths in the world. In terms of how important a cause of death it is in the US, in 9 months through September, this is the number of deaths we would have expected from the 10 leading causes of death, and COVID-19 is solidly there in third place. So this is a serious evolving pandemic. You know, we tend to talk about cases rose quickly in the US and rose again, came back up. Cases are dependent in part on testing. So if you look at deaths, you see a rather quick rise in deaths in March and April, then it spiked again in the middle of the summer, and has either been level or slightly increasing in the past couple of weeks. So again, just as it is in the world, the pandemic isn't hitting everywhere in the US at the same time. We have states like New York, New Jersey, Rhode Island, Connecticut that had a quick rise and then relatively few additional deaths. States like Virginia that have been slowly rising, states like Tennessee that seem to still be going up, and then states like South Dakota that are hitting their peak now. This is a map of where all the cases in the US had been as of August 13th. Now I'm going to transition from August 13th to just the last 2 weeks, and you'll see all of these dark counties in rural America. That's where the pandemic is evolving right now. So what started in the large urban areas now seems to be spreading into our rural areas, and those of you who know Tennessee can see that those are the counties that have been impacted here. So it's an evolving, changing pandemic. I'm not going to say any more. I'm going to turn it over to Dr. Moorman, who will share his slides. We hope.
Yes. Can you see that?
Yes.
Right. So I'm going to talk about the virus, the disease, and the treatment and prevention efforts that are going on currently as of October of this year. So as Dr. Wykoff talked about, this is obviously a novel virus. It's a beta coronavirus that emerged in December of 2019, and it was a bat virus. It is not the first of the bat viruses we've had to deal with, and many of the bat viruses that we do see in infectious diseases are fairly nasty. They include things like rabies, Ebola, and Marburg. So bat viruses are a problem, and I highly suspect they'll continue to be a problem over the ensuing decades. This virus is unusual in that upon entering into the cell, it has to do so through a receptor called the ACE2 receptor, or angiotensin converting enzyme receptor. And it does so through a protein that is expressed on the virus's surface. And that's called the S protein, or spike protein, because it looks like a spike. That S protein you might have heard of because it is the major target for our vaccine initiatives, which I'll talk a little bit about later. Once it gets into the cell, it's able to reproduce itself, it releases its viral RNA, and there is a polymerase, which is an enzyme that makes more RNA. That particular polymerase may or may not be the target of remdesivir, one of the drugs that's out, and I'll talk a little bit more about that later. That drug is not specific for this particular RNA polymerase. It actually acts on many RNA polymerases, but they believe that's how remdesivir may work. This particular virus really likes the bronchioles and alveolar spaces, and the pneumocytes in the lung express a fair amount of the ACE2 receptor for the SARS-CoV-2 to bind to. So the coronavirus family is, at this point, about 7 different coronaviruses with which we have been familiar for several years. coronaviruses are responsible for about 20 to 30% of common colds as it is. So they're known to cause respiratory infections. But starting in around 2003, we started seeing the emergence of the beta coronavirus family. And these are particularly nasty. And they include SARS, which emerged in 2003 and killed about 650 people in China, but was not clearly very infectious. In 2012, MERS, or Middle East Respiratory Syndrome, another coronavirus, emerged and again killed about 850 people and was not clearly not that infectious, in that it was able to be stopped with relatively little effort overall. So, of course, last year, the new coronavirus that emerged was not like this, was way, way more infectious than these previous two viruses, and that's why we're in the position we're in right now. So the disease itself clearly has a wide spectrum of manifestations, everywhere from asymptomatic people with no symptoms whatsoever, pre-symptomatic people, so they're infected but they're not sick quite yet, and then very symptomatic people. It is acquired by exposure to microdroplets that are in the exhalates of infected individuals, or by contact with viral particles in infected fomites, and the average time from exposure to symptom onset is about 5 days. The vast majority of the people get sick within about 12 days, but there is a range. So there are some people that develop symptoms within 2 days of infection, and some people who develop it 14 days after infection. So it's not hard and fast, none of these are. The most common symptoms are fever, dry cough, and shortness of breath. If you look radiographically or at x-rays, you might see this. You might hear about this on the news. They'll talk about these ground glass opacities. And these are just areas of infection and infiltrate in the lungs, basically pneumonia. And it looks a little more unusual on x-ray. But that being said, flu can look like this. Many, many other infectious diseases look like this. So you can't say, oh, this is definitely COVID based on just looking at an x-ray. There are some lab abnormalities like low number of lymphocytes or elevated LDH, lactate dehydrogenase. Again, any kind of pneumonia can do that. So, especially viral pneumonias. So I don't think you can hang your hat on that for diagnosis. Our diagnosis is primarily based on a polymerase chain reaction, which measures the actual presence of the virus in the person's body. So in terms of symptoms of COVID versus cold versus influenza, you can see here there's a tremendous amount of overlap. If somebody comes in with dry cough or fever in December, I'm going to be very hard put to tell you whether or not it's influenza or COVID. And so our testing is going to obviously have to be robust if we're going to really be able to differentiate these as we get colder and colder every month. But there are a couple of things that we might kind of hang our hat on. We know that many, many people develop different kinds of symptoms with COVID, but most of them will have shortness of breath, cough, fever, or in particular, a loss of taste or smell, which is fairly unique among infectious diseases. I don't hear that very often, but I'm hearing that a lot with our patients that we're seeing now with COVID. So I think a loss of taste or smell is something you can really rely on in terms of triggering the thought that this could be COVID. There are a certain amount of people that develop fulminant disease that is characterized by sepsis and acute respiratory failure. Those people are hospitalized usually and often end up in the intensive care unit. About 5% of the people with COVID do end up being hospitalized, and about 20% of those that are hospitalized end up having to go to intensive care and often have to be intubated. More than 75% of patients hospitalized with COVID require supplemental oxygen. And often in the emergency rooms, it's the hypoxemia or lack of oxygen that drives them to be admitted in the first place. So there are, of course, many risk factors for this. You know these already. You've probably heard these on the news. Any immunocompromised state, including transplantation patients, cancer, AIDS, on these patients that are on these kind of fancy new drugs that suppress the immune system, those people are all going to be at higher risk because their immune systems are already weak. People with lung disease intrinsically, or people who smoke, people with obesity, people with diabetes. Also, risk factors would include people of color, and certainly the African American community is more highly susceptible in terms of more severe disease. So if you look at what happens when people get COVID-19 infection, the immune aspects of this are very, very, very interesting. So we know that protective immunity develops fairly rapidly in most of the people that get this infection. And clearly, younger children, younger people do not get very ill. And when we look at those people, they develop neutralizing antibodies to the S protein very quickly. They also develop cellular responses. So their T cells, which are important for detecting infected cells in the body, are very ramped up. They're going after this virus very quickly. And those people do very well. And those are the green in this picture. They recover really well. If you look at the people that don't do so well, and they're often quite aged people, but if you look at them, they have some evidence of immune dysregulation. They are not able to handle the virus appropriately up front, and they develop what's called a cytokine storm. Cytokines are chemicals that are produced in the setting of inflammation in the body during infections. But in this scenario, that is completely out of control. And these cytokines can make you very, very ill. They cause you to drop your blood pressure, to end up in the intensive care unit, to be intubated, and to die. So those people have a different immune response than most of the people, the vast majority of the people that do recover. We're actually looking into this. We're very interested in this. Anybody out there who's had COVID, I want your blood. We've been collecting blood since about June on anybody who's had COVID because we're interested in defining those responses. So we know that the case fatality rate for COVID varies markedly by age, being quite low in people that are young and quite high in people that are old, especially if you're over 85. It's ridiculously high. This is just a graph of the United States as of, I think, yesterday or today. And you can see the case fatality rate currently in the United States is about somewhere in the 2% range, 2+% range. And those are the actual ratios between the confirmed deaths and the confirmed cases. So I wanted to talk a little bit about the treatments that are out there, and I've got kind of good news, kind of bad news, which has been the story of this entire virus for me. We now know that remdesivir, the drug I'm sure you've been hearing about, is FDA approved. It was FDA approved this week, but I can tell you the data for it are relatively weak, and it certainly is not the knockout drug we expected it to be. As I told you, remdesivir works on probably an RNA polymerase, but it is not specific to the COVID RNA polymerase. And if I've learned anything from HIV and all the years and years of drug development for HIV, most drugs have to be very specific to work very well on viruses. Viruses are very, very difficult to handle and stop with just drugs, especially once they've kind of left the barn. It's really hard to control them. So we do know that remdesivir is found to be superior to placebo in shortening the time to recovery in people with lower respiratory tract infection. And in those studies, at least some of those studies, there was a trend towards reduced mortality, but not a strong trend. What we really wanted to see was a dramatic decrease in death. If you wanted a more dramatic decrease in death, then you might want to stick with more the dexamethasone, which is now a standard of care. It is a steroid. And some data with hydrocortisone has also suggested it would work as well. It has been shown to reduce 28-day mortality in patients requiring supplemental oxygen. So if you need oxygen, you're in the hospital, it will reduce your mortality. This is an easy thing to do, relatively speaking. And I think that everybody should get dexamethasone if you're coming into the hospital, especially hypoxic. Convalescent serum has been bantered about now for several months. There are a lot of data from other studies to suggest this should work, but so far the data that we've gotten has not been very exciting. In a randomized trial of 103 patients with COVID, the plasma did not shorten time to recovery, and a very recent larger study out of India showed no difference in progression to severe disease or death. Now, you would think this would work, and I think part of the problem is to do these trials is difficult. If you're coming into the hospital right up front, you might benefit more. than if you've already been sick for quite a while. If you're already developing antibody, it doesn't seem like this getting somebody else's convalescent serum that already has antibody is going to help you that much. So it's going to probably benefit you more earlier. And similarly to that, I want to talk a little bit about Regeneron, the Regeneron product, and I don't own stock in anything, but these are monoclonal antibodies that are commercially made and made in a lab, and they're combinations of antibodies that target the SARS virus. So in those studies, which are very early studies, the combination markedly reduced the viral loads in those patients that had not developed an antibody response yet. So if you come into the hospital with acute infection and you're ill and you have not developed an antibody response yet, those people had dramatic decreases in their viral loads. And that's probably going to be a very good thing. This is the drug that President Trump got. Regeneron makes that. There are many other companies that are making these kind of combinations. They're doing combinations because they think that will prevent having to face a virus that might be resistant already to one antibody. So I have a lot of more excitement about monoclonal antibodies than I do about the convalescent serum, but it's possible that the convalescent serum would work if you check the patient who's donating the antibody first, and you made sure that the patient you're giving it to has not already developed antibodies. So I think going forward, what you'll see is they'll be giving people monoclonal antibodies very early after admission. I wanted to mention tocilizumab, which is a drug that blocks the IL-6 receptor, which we thought might help with some of this cytokine storm. It did not work. So just wanted to bring that up in case anybody wanted to know. That drug will probably not be going forward. And last, there were some questions about vitamins and supplements, and I think at this point we can't say much about them. Vitamin D is perhaps the most exciting of these, if you think that anything is going to work. There were studies that showed that people who are vitamin D deficient were more likely to be sick with COVID or have worse outcomes with COVID. And there was some minimal data as I presented here, and this is not strong data, not large enough groups, but it did look like people that got vitamin D were less likely to need ICU care. I think that that's worth looking into. I can tell you vitamin D has been an issue related to infection for at least 20 years, and there are a lot of data in other diseases that vitamin D has an important role in infection. So I think that's not an unreasonable one to look at. And I'll remind you that vitamin D deficiency is common in the same groups of people that do poorly with COVID. It's common in the obese, it's common in people who are hypertensive, and it's common in people of color. They are all more likely to be vitamin D deficient. So it's something that is probably at least worth looking at. And I'm going to skip over to vaccine progress because there were some questions about that. So there are currently 4 phase 3 trials going on, and I think we should just step back for a minute and think about that. We knew almost nothing about this virus 7 months ago. And we have 4 phase 3 trials, which usually take multiple years to get to. And one of them is likely to be announced, the result of which is probably going to be announced in the next week or two. And that is the Pfizer vaccine. It's a phase 3 mRNA vaccine trial. It's already enrolled more than 42,000 people. 36,000 of them have already received the second dose. We should get the results in the next 2 or 3 weeks, and I expect a emergency use authorization within the next month. Now, that doesn't mean you're going to get the vaccine available to you in the next month, but it may mean that it is available to be distributed. Moderna has a vaccine that's gotten a lot of play, and in their non-human primate studies, it was very impressive. In the chimpanzee models, it showed robust immune responses and protection against challenge by virus when they tried to give the chimps the virus back again. So AstraZeneca has a nice vaccine trial that showed 100% neutralizing antibody development after 2 doses. That study did have to be paused. You might have heard about that, but that is not uncommon with clinical trials, and it is now restarted. Johnson & Johnson also has a clinical trial, phase 3, that is a single-dose vaccine. I think it's the only one that is a single dose. And that trial is paused, but we expect it to be resumed very quickly. Most of these started somewhere in the June to July time period, some August. So we should know all the results fairly quickly. There are 6 vaccine candidates that are being targeted for industrial scale manufacturing. Those are 4 of them. And they are trying to procure and deliver the authorized vaccines as soon as they get the emergency use authorization. I would expect for you out there in the real world to see prioritization of delivery. So I think that you're going to see the people that are most at risk get the vaccine first. It's going to be the elderly, the immunocompromised, and those are the people that should get it first. Unfortunately, I don't think a lot of these studies were necessarily done in the elderly. This is always my complaint about vaccine trials. So I don't know that they're going to have as great a response as, say, the 25-year-old college student. But we hope that it will be enough to protect them from at least severe disease. So do expect prioritization and don't expect that everybody's going to be able to get it immediately. I do expect that some people will be getting it before the end of the year, if I had to guess. So I'm going to go ahead and release this over to David and let him talk to you now, if I know how to do this.
There you go. So now Dr. Kursky is going to talk, and then we will start doing the questions and answers. We can see that, Dave.
Okay, so you can hear me. So I'm going to talk about basically the epidemic in our area. So I think everyone knows that we're entering our 3rd wave of the pandemic. We've seen cases increasing over the last several weeks. People have asked why that is. It's not 100% clear why. I think we all expected another wave in the fall, maybe later on when it got colder and lots of people are indoors, but it's happening sooner than that, which is a little bit worrisome, just because, it's hard to say where it's going to go. So, there's lots of things going on. Some people are getting frustrated with wearing masks and doing other prevention measures, so maybe they're not doing those as much. Schools are back in, colleges are back in, so we know there's lots of cases and transmission among those age groups. So there could be a variety of reasons that we're seeing that wave now. So I think we're talking mostly to college age people tonight. So people in that age group, young adults, represent the highest proportion of positive cases in our region and in the state. We know there's lots of social interaction. I always say that your lives are more interesting than us older people. So you have more social contacts. There's more room for transmission. There's also more asymptomatic spread. So people don't know they're infected and are around other people. The thing we want to do is protect people in older groups who are the most vulnerable, most likely to have some high risk condition. So some people have proposed a strategy of herd immunity where we just stop doing anything to prevent the spread of coronavirus, let it spread in younger people, and somehow it's not clear how they propose to protect older people. Unfortunately, we know that young people, a lot of them live with older people, whether it's their parents or grandparents. School kids often in our area are living with grandparents. We all, have contact with older people in the community. So it's kind of hard to let it spread in one group and not think it's going to jump over to people that are more likely to be hospitalized or die from coronavirus. We also don't know that once you're infected naturally that there's going to be lasting immunity. So that strategy could lead to just wave after wave of coronavirus. As people recover, then lose their immunity, and then potentially can become reinfected. So one of the outcomes that we want to prevent bad outcomes is hospitalizations. Unfortunately, we've seen a large increase in hospitalizations over the last couple of weeks. One of the problems with that, well, so there's a couple of problems with that. One is that, you know, we have the potential to overwhelm our healthcare system, especially with flu season coming. We can overwhelm the healthcare system during a flu season. If there's coronavirus and flu, you know, it's likely that we're going to see healthcare system overwhelmed. The other thing is, you know, that's more people that are hospitalized. Those are people that are high risk. And those typically after hospitalizations and cases go up, a couple of weeks later, we'll see an increase in deaths. So we expect that to occur in the next couple of weeks. This is actual data from Ballad. So just a couple of weeks ago, the number of people hospitalized in Ballad hospitals was in the 60s. So it's gone up quite a bit in just a short amount of time, which is worrisome, especially as Ballad points out, even if everybody, you know, stops spreading it today, there's already people out there that have become infected and that in the next week are going to get sick enough where they'll have to go into the hospital. So, you know, the course is already set for a continued increase in hospitalizations. And as I mentioned, hospital deaths usually follow hospitalizations by a couple of weeks. You know, when cases spiked over the summer, a lot of people were saying, well, you know, there's lots of cases, but there's no deaths. But everyone in public health was saying, and we know from influenza and other diseases that deaths usually lag a couple of weeks behind cases. So we expect that deaths will go up. So unfortunately, deaths don't occur kind of uniformly in the population. Some people are more at risk than others. So we have the vulnerable population. Some of that is among African Americans have a 2 times higher rate of death, and various ethnic groups have higher rates of cases and also hospitalizations. So, you know, it really begs the question, you know, when are we going to recognize that Black lives matter in our policy discussions and also address determinants of health with an anti-racist perspective? Seems like I teach infectious disease epidemiology at ETSU, and with many of our infectious diseases, we're talking about racial disparities and outcomes from diseases. So a lot of people want to compare coronavirus to the flu. Dr. Wykoff said earlier that currently we have, you know, it's order of magnitude higher deaths from coronavirus so far than from last year's flu season. Last year's flu season was mild, but really, you know, 6 to 11 times more people have died in the US so far from coronavirus than from flu. One of the concerning things is that we don't even really know where we are in the pandemic. We could be, this is the pandemic curve, just a schematic of a pandemic curve. We could still be, you know, low on the slope and still have a long way to go. So a lot more potential deaths, you know, this fall and winter, and potentially subsequent waves. So it could continue to get worse. So I did want to address, talking about the difference between flu and coronavirus, some of the assumptions. So a lot of people want to know what's going to happen from here on out with coronavirus. You know, some people are hoping it just goes away on its own. I don't think we have any evidence that that's going to happen. You know, what if we get a vaccine? You know, what if we do certain measures like wear masks? What's going to happen? So I know people have seen on TV and, you know, maybe read about different models predicting what's going to happen. So one interesting thing the CDC puts out, so if you have a model about trying to predict what's going to happen, you kind of have to know what's going on with coronavirus. And the CDC actually puts out basically parameters for people to use when they're modeling so that they can accurately try to predict what's going to happen. So one of the questions we received beforehand was what is our sub-zero, what we call the basic reproductive number or the transmission number. Basically, this is the number for every case, how many other people do they give coronavirus to or whatever disease you're talking about. So the CDC currently says their best estimate is that each person with coronavirus transmits it to 2.5 other people on average. There is a big difference in fatality rate by age. So for each person that gets infected, what proportion of that age group dies. So it's highest in people 70 and over. About 5% of those people who become infected die from coronavirus. And that's obviously one of the groups that we want to try to protect. Younger people, not so much, which is good news. Although in terms of community transmission, those people can still spread it. So how can they spread it? So we think that about 40%, or CDC estimates about 40% of infections are asymptomatic. So people are infected and can transmit coronavirus, but they have no symptoms. So they may not know to go get tested. They think people that are asymptomatic can spread it about 75% as well as someone that has symptoms of cough and fever. And they think that about 50% of transmission is occurring from asymptomatic people. The other interesting thing is they think this mean ratio of estimated infections to reported case count means for every case we know about that's reported to public health, CDC estimates there's between 6 and 24 other cases out in the community that we never know about, and they estimate an average of about 11. So if you look at our numbers, you can multiply them by 11, and that's what CDC says is a realistic estimate of how many cases are around, currently active cases. The White House Coronavirus Task Force produces a report for states each week. And there's a map. So currently Tennessee is red on their map, which is the bad color to be. And some of our counties in Northeast, you can see, are also red. Let's see. So they also give some recommendations to states. So one of the recommendations for states that are in the red zone, they told Tennessee ensuring mask utilization statewide will prevent unnecessary transmission and deaths. So I think that's a really important point. There's a lot of pushback right now against masks. Masks are not 100%, but they're one of the best tools that we have right now to prevent illness and death from coronavirus, and especially unnecessary. So, it's not really that big of a deal to wear a mask, although some people might argue that. But if you think that you could potentially prevent illness and death by wearing a cloth face mask, it seems like that should be a reasonable thing to do to help protect other people, especially those people most at risk in our community. There's actually some data on states that have mask mandates versus states that don't have mask mandates. So there's higher case rates on average in states, or in counties. This is county data. There's also state data, state by state comparisons with statewide mandates versus not. But this is counties in Tennessee that have mask mandates here versus counties with no mask mandate. And you can see there's a gap. So this is really those unnecessary transmission and deaths related to people, in counties that don't necessarily want to follow prevention measures, don't want to try to decrease transmission by wearing masks and doing other measures. So really, I think if we are willing to do that, we can prevent these unnecessary deaths, that are represented by that gap. The other thing we're battling in public health is the infodemic. So there's lots of information out there, both correct and incorrect. And one of the big parts of what we do every day in public health is try to counter misinformation. This is a tweet that was put out in the past week, I think, by the American Medical Association, trying to correct misinformation that hospitals are, inflating coronavirus diagnoses and things like that to get more money. So there's a constant battle to try to, correct misinformation, whether it's healthcare or public health about coronavirus. There have been studies that have showed, this is a study that shows, regardless of your political party, if you listen to mainstream broadcast media, so the TV news or mainstream print media, the newspaper, that correlates with accurate information and accurate beliefs about how to protect yourself from coronavirus, versus if you get most of your information from social media, you would be more likely to be misinformed or believe conspiracy theories. So again, some of the things we're trying to fight against. And, we named this talk, talking about fact versus fiction. I think providing accurate, unambiguous public health messaging, so where public health and elected officials are both saying the same thing, a unified message for people, so it's not confusing, will prevent unnecessary transmission and deaths from coronavirus. And I will stop there.
Well, thank you both. Those of you who submitted questions in advance will recognize that Dr. Moorman and Dr. Kursky very helpfully addressed many of your questions in their presentation. I do have a number of questions, and David, I'll start with you since you just spoke. A lot of people are asking questions about what they should do in the upcoming holiday season, as far as work, church, family gatherings, restaurants, schools. What advice would you have for folks over the next, the holiday months, if you would?
Yeah, it's really hard to say anything's safe. There's kind of a gradation of, from fairly safe to not very safe. Obviously staying home, doing things virtually, having groceries delivered, all that is, is about as safe as you can get. Versus, if you go to a big gathering, lots of people, no one wearing masks, people traveling from lots of different areas that potentially could have higher rates than we have here, although we have fairly high rates, it's going to be more risky. Visiting family members, especially people that are older or that have illnesses that put them in high risk for coronavirus, is going to be dangerous for them. So I think there's, kind of people have to figure out where they're comfortable along that range. So we would definitely recommend, trying to be safe, especially among people that are high risk. Limit gatherings, try to social distance, physical distance within gatherings, wear masks, especially try to protect those people that are at highest risk from bad outcomes from coronavirus. No one wants to visit people over the holidays, come home, find out you're infected and have to call up all your family members, and God forbid one of them gets sick and potentially has a bad outcome. So just trying to be as safe as possible. Outdoor things are better than indoors. So there are lots of recommendations on the CDC website about how to make things safer over the holidays.
Great. Thank you, David. Dr. Moorman, a number of questions came in about what people should do if they've been exposed, or they think they may be infected, or they may have been with, a little, questions around the basics of quarantine, isolation, things like that. Maybe you could say a few words about that for folks.
So this is basically the bane of my existence and David's existence on a daily basis. There are fairly clear guidelines on the CDC's website if you want to look at them. So once you've become infected, let's say you're exposed and you're tested and you're positive, you're going to have to be isolated. That's different than quarantine. Isolation means you got the virus, you're going to be isolated, and most authorities would recommend a minimum of 10 to 14 days, and you have to be well by the end of that quarantine that isolation before you can be released. So I think that's fairly standard. The bigger issue we've come up with is if somebody is positive and ill at home and they have people that live with them and they cannot not be away from those people also have to be kept away from other people, and that is called quarantine unless they develop symptoms and develop the disease, in which case they are also in isolation. So, but the quarantine period can be quite a long time, because the person who is ill can be shedding the virus for 10 days, in which case that person technically should be in quarantine for up to 24 days or even more, depending on how the patient's doing. So we have to take it on a case-by-case basis. David gets calls about this every single day, and all of his nurses do, and we kind of have to figure out where the exposure was the risk that's involved in it. And sometimes these people are healthcare workers and we really need them. And so there's other things that come into the equation. But for the most part, if you're exposed, you need to stay away from people until you've been tested and or your quarantine period is over.
Yeah, so I'll just remind people about the rationale for that. As Dr. Moorman said, the incubation period for coronavirus is 14 days. So anytime in the 14 days after you're last exposed, you can develop infection and become infectious. And one of the problems is we think people can spread coronavirus for about 2 days before they develop any symptoms, so they won't even know it, that they're sick, and they'll be spreading coronavirus to people at school, to people at work, to people in their family. So that's really the rationale for the 14 days quarantine, is the incubation period and asymptomatic spread.
Right. Oh, there's a question that came in on the Q&A site that also was something that was submitted in advance. And that is, the way it was worded here is, if the three of you, and I'll say the two of you, were tasked with implementing a national plan moving forward, what would it entail? And that sort of plays off the questions that we got early on, which is, what could or should we be doing differently? How, if you compare us to other parts of the country or compare the US to other countries, what could or should we be doing differently? And again, for everyone's interest, this is not a political question. This is a public health question. So I'll open it up to either of you. David, you want to go first?
Yes, I'll take a stab. So, really, the converse to doing the herd immunity approach, where you just let it run wild, and, young people may fare fairly well, whereas older people die. Really, the main tools that we have are social distancing, wearing cloth face coverings, isolation and quarantine related to cases that we know about, and then trying to do just things more safely, and whether it's virtual meetings, whether it's trying to social distance in schools, whether it's trying to do events, holiday events like are coming up differently. So we've proposed, people have asked about having parades, so we've proposed to keep people in their cars and they can drive through the lights, kind of like the Bristol Motor Speedway. Just figuring out safer ways to do things to prevent, again, that unnecessary transmission and deaths from coronavirus, until we have an effective vaccine where we can get actual herd immunity, hopefully.
I'd also like to see maybe a more robust risk stratification tool where we can say, okay, this person is clearly at high risk. We need to do everything we can to keep them in their bubble and protect them because they're the ones that are going to die. We should be able to predict that by now. We've got enough information to know that their risk of death is going to be X as opposed to somebody who's not, and then kind of look at their community, what community they're in, and protect them as much as possible. If you've got grandma living with a little kid, that's going to be in school, that's going to be a problem. You're going to be a greater risk. And if grandma really needs to be protected, maybe we need to think virtual school for that child, as opposed to another one. Just some of it's common sense, but if we had risk stratification, I think it would tell everybody where they should be going, give them a direction.
I think that makes sense on an individual basis. From a societal standpoint, for either of you, what would be a signal that we need to do something differently? Whether, everyone always talks about we have to lock down. Well, that's a rather sensitive topic, but what's a signal that things are getting out of hand?
Yeah, I think one of the main outcomes we look at is hospitalizations, and I have those slides about hospitalizations are increasing. We expect them to continue to increase. We have plans on our shelves to do alternate care sites where people are being taken care of in inflatable tents outside the hospital or in alternate care sites. One problem, even with those, no one really wants to go there, and we hope we don't have to take that off the shelf. But we can open up an alternate care site, but the question is, there's already staffing shortages of nurses within the hospital, so who's going to man those? Is it going to be volunteers, non-medical people? So I think that's one of the main outcomes we want to try to avoid, is the healthcare system being overwhelmed, where that's just going to increase the proportion of people that die. because there won't be, we might not have enough ventilators, enough medicine, enough staff to take care of people. So we want to prevent our healthcare system from getting to the point where we can't take care of people at the, the level that we can do now.
Right. So we basically don't want to end up like what happened in New York, where they overwhelmed their healthcare system. And the state has metrics or rubrics that they follow very closely. And every day I get a printout of them, and it includes things like, what's our ventilator use? How many available ventilators do we have? What is our percentage of ICU beds that are open? What is our percentage of floor beds that are open? And all of those things, I know the state, the health department, certainly the governor's office is following very closely, because that tells you when you're in trouble. I think that once you tip over into that, you have to do something different. I think if you overwhelm your system, we're going to have to trigger something else.
A couple of questions that have come in. A couple of quick ones. There was a question about blood type and COVID risk. Jonathan, you want to address that real quick?
So there have been some suggestions that certain blood types are less of a risk, like O, than maybe the other blood types. I think that that's a very general idea, and I would not at all bank on that. If you're 85 and you happen to be O negative, that's nice. You're the universal donor, that's nice, but that's not something that's going to protect you from severe disease with COVID, ultimately, I suspect. So that's true of many infectious diseases, by the way, that there's differences in blood types, but it's not enough to allay severe disease in the big picture.
Another question that came in, David, for you, and it's an important one, and that is, we don't talk much about indoor ventilation. How important is that? Is standing air versus moving air? I know we've looked at it in airplanes perhaps more than offices, but what do you think?
Yeah, there's actually a whole rubric that was published related to, the risk associated with being in a crowd outside versus being in a crowd inside with poor ventilation. So there is definitely kind of a gradation of risk. There is some suggestion of occasional, that potentially coronavirus can be spread by an airborne route. So that means, someone coughs that's more than 6 feet away from you, maybe those small particles can drift over to you. That's more likely to happen in an enclosed space, whether it's a car with all the windows up because it's raining, or a poorly ventilated small space with a bunch of people crammed into it. So, there is that possibility. We think for the most part, coronavirus transmits through droplets. So that's, you have to be close within 6 feet of somebody, but there are opportunities, especially with things like singing, where you're projecting or coughing can, spread those particles farther.
I should mention that the National Institute of Health has ongoing studies on this particular question, very kind of novel approaches to answering this question specifically for COVID. They sent out requests for applications that have to do with environmental health, and I was able to be on some of those study sections. They're very interesting. I think we'll know more about that in the very near future.
A related question, in my last weekly update, I mentioned that one of the 4 things I was concerned with was public losing trust in their regulatory and public health agencies. And a question came in, both of you have mentioned recommendations and information from the CDC. Do public health professionals generally feel that the CDC recommendations are robust enough and trustworthy? And I'll leave off the rest of the question.
Yeah, so, CDC is the agency that's, taken us through every major outbreak from, whether it was, Legionnaire's disease in the 70s, HIV. Many of my colleagues at CDC were in West Africa during the Ebola outbreak. So CDC really is the experts. There is some suggestion that they stumbled, on the first possession with vaccine, or not the vaccine, I'm sorry, testing. But, to pull the first string quarterback out of the game after the first possession, because of a fumble like that, probably maybe hurt us. But I think CDC, all of our recommendations on the Tennessee Department of Health website are basically straight from CDC. They're the experts in whether it's infection control in hospitals, whether it's community prevention, vaccines. So they are still who we look to. Public health officials, that's who we look to for our information. And I think the public should too, despite what, people in the media and, officials may say about that.
I would second that, what David said, and also remind people that this is not a virus we knew anything about 8 months ago. And we learn things as we go along, and recommendations are going to change. That's nothing new for the CDC. Nobody cared before. I mean, David and I have been dealing with the CDC recommendations changing over the years for all these different things because you just don't know about a particular disease. It's just that now there's a lot more media focus on it than there ever was before. And they say, oh, the CDC's waffling or they're changing. But what they're doing is adjusting to the pandemic and figuring out how to handle it best. And that may lead to a change in policy. So be it. You have to do it based on the science that comes in.
Yeah, I mean, there could be a temptation not to change, but you really have to, if you have information that suggests that you can do better, then we have to adjust.
I mean, I spent 11 years at the Food and Drug Administration, and I'll tell you, you get criticized if you go too fast, you get criticized if you don't go fast enough. But basically, in my experience, most scientists are trying to do the right thing. And the winds of politics blow right or left, but at the end of the day, we've got to take the science as it is. There are a couple of questions that have come in on who is an essential worker. Would either of you like to address that?
Yeah, so we get lots of questions about that. So the main reason that comes up is because there are, I can't remember how many sectors, 13 or 16 sectors of essential workers. The main one that we deal with is healthcare workers. So under the essential worker, what we say clause, when you're trying to figure out quarantine. So if a healthcare worker has been exposed to coronavirus, there are some situations where during their quarantine period, they would be allowed to work. And that would be basically if by them not working, the hospital is short-staffed to the point where it would put patients at risk. So the risk of them not working is greater than the risk of them working. So they would work, they're not infected, they don't have coronavirus, but they've been exposed, they might become a case. So they are allowed to work while wearing PPE and also social distancing from colleagues. There are other sectors, food, defense. So certain, basically sectors where if we would quarantine them, it would put the public at risk some other way, like your lights don't work or there's no safe drinking water or food. So so there is that provision, but it really, it doesn't apply to everyone in the sector. Just if, those people, there's no replacement, no one to replace them, and by them being out of work, it puts the public at risk greater than if they work while they're in quarantine.
We talked briefly about masks, so I'll ask a completely unexpected mask question. And that is there a safe way for kids to trick or treat this Halloween?
Yeah, so we're getting that question. I don't know if Jonathan wants to
Well,
chime in.
So obviously it's happening in our community. Many of the church groups are having trunk or treats. The way they're doing that is they're social distancing. The kids are wearing masks. They are having trunks that have treats in them, but there's nobody in the trunk. There's no human there. They just go by and pick up the candy. So that's obviously a lot safer without any physical contact. You've got at least 6 feet plus distance, and they're wearing masks. So that's pretty safe. One guy said he was going to get a big tube and drop the candy into a tube down, a 6-foot tube down into their bag. I like that idea. There's lots of unique ways to do it. But David, what else are you recommending now? I didn't think Washington.
Well, I was just going to say it's a tough time to be a kid, really. Actually, for all of us, it's been stressful. But we do again, there's like, there's safe and there's unsafe and there's, things in between. We just try to help people make the best decisions they can to protect themselves and other people. So, just by trying to do common sense, and this, CDC has recommendations about different holiday events also on their website, doing things to try to make it safer. Each person has a different tolerance for risk. Some people are happy now to go out to restaurants and things like that. Other people are staying home, only doing takeout, getting groceries delivered. So it really depends on what your tolerance for risk is, for you and your family. But there are definitely ways to do church and events, visiting families safer.
Thanks. I hope you all are comfortable answering a few more questions. We're sort of at time, but there's a lot coming in, and if you're willing to stay another 6 or 7 hours, we'll get maybe another 30 minutes. We'll try to get them done. Jonathan, there's quite a few questions that have come in on vaccines. I mean, obviously, some of them are sort of hypothetical. When do you think we'd have a vaccine? How effective would a vaccine need to be? But an interesting question came in, and that is, if a vaccine is released on emergency use, would that be the only one that's available? Or would we anticipate having multiple vaccines?
Oh, no, there will definitely be multiple vaccines. There's not going to be just one. And these are being released globally when they come out, so that different regions may have different vaccines. I suspect the US will have a wide variety of vaccines. As I said, the Pfizer one is probably going to be the earliest one, just because it's closest to releasing their data, and I presume their data will be strong enough. Difficult to do these trials, you have to realize, because it's one thing to show that a vaccine is immunogenic, meaning it shows that the person has an immune response to it. It's another thing to show that it's protective. Because in order to do that, they have to actually be exposed to the virus. And right now, we're not really willing to expose somebody in a clinical trial to the virus on purpose. I can tell you, in the past, I used to run flu trials, and we would give them flu. We don't do that for coronavirus. It's considered a biosafety level 3 virus right now. That's pretty high up there. So we wouldn't do that. But when the data comes out and it's released, I expect it'll be one after another after another. The data will be coming out probably within 4 to 6 weeks of each of those vaccines that are currently in trials. And hopefully the data will be consistent. Hopefully it'll be protective. All of them will be protective. If you look at the phase 1 and 2 data, which is the early trial data in primates or in whatever model they use, they're very robust vaccines. They really develop a lot of neutralizing antibody. They develop a good cellular response. So we would hope that would translate into working in humans. It certainly did work in the monkey models.
There's a question's come in, which is, I think we've sort of answered it, but it's worth asking again. And is there any risk in getting routine medical or dental care in our region right now?
Yeah, so I was going to say, again, it goes back to the kind of gradient of risk. So I think most providers are doing things that would mitigate risk. So in healthcare, basically, in at least in most healthcare settings, people are doing what they call source control. So all healthcare workers are wearing masks all the time in case they are asymptomatically infected, don't know it yet, they don't transmit it to patients. There's also, waiting rooms have been changed around. They're often calling people from the car directly to the exam room. People are wearing extra personal protective equipment to avoid transmission and avoid healthcare workers getting sick. So it's definitely safer. And I definitely would not put off anything that's serious, because of the risk, because for the most part, physicians in the community and the hospitals are all trying to make it as safe as possible for people. And we've also seen that, we've seen that there's been excess deaths related to people not going for medical care and then ended up dying of heart attacks, asthma attacks, different things that, because they didn't seek care because they were afraid of coronavirus. So there's definitely things that you should definitely go for. Other things, if people are concerned, I would call ahead to your doctor's office and just see what they are doing to help make it safer.
Yeah, I think all of the doctors' practices are using telehealth, and it's important for people out there to know that they can access that. They need to be in contact with their health care. They can't just go without health care, because I think that you're going to get worse outcomes from doing that if they get no care. You don't want somebody dying of gallbladder disease because they didn't want to go in because they were afraid they were going to get COVID. Or depression. We've had a significant problem with depression with this. I mean, all of us have. This is just so difficult for everybody. And we need to have tools in place to deal with that. And telehealth will at least ameliorate some of those. The people out there need to know they can contact their doctor and get into telehealth very quickly.
Thanks. Earlier, I asked sort of a generic question of sort of at what point do we know we as a society need to change? But a very specific question came in about high school sporting events with crowds gathering and so on. And what advice would you give for folks considering attending games, or whether they should be modified in some way?
Yeah, so my advice has always been that, the safest thing, people always say the sporting events are for the kids, but then there's huge crowds. So, if they're really for the kids, I think the safest thing would be to not have a crowd and maybe just televise the game would be the safest thing, or to limit the amount of people that can come. And then also to definitely require face masks if there are people in the stands. But I think the safest thing, if it's really all about the kids that are playing, would be to not have people in the stands, and then have family members, like I said, watching. A lot of games are televised already. That would be the safest thing. Again, there's gradations. You could have people spread out in the stands potentially, but we've all seen on TV, the Friday night football games where people are crowded and not wearing masks. And obviously that's the highest risk kind of situation, especially, if we want football and other sports, volleyball is going on now. If we want those things to be able to go forward, parents have to be responsible, just like the kids are trying to be responsible on the field.
I think sports in general are very challenging, and I think David would agree because of the youth, the players. There's a fair amount of coronavirus going through these sports groups very quickly. Very, very hard to control that kind of thing. We want them to experience it, but at the same time, we know that it is not going to be considered a low-risk event, I think.
One of the questions that came in before and has been sort of re-asked now is how much information can or should the public have about specific clusters and outbreaks and things like that?
Yeah, so we do publish clusters related to nursing homes on the Tennessee Department of Health website. And we would also alert the public if there's any ongoing transmission, related to, any kind of facility, whether it's a school, whether it's a restaurant. But in situations where there's not evidence of ongoing transmission, if we've isolated and quarantined everybody, we don't necessarily alert people. Because really with so much community spread, you might know that there's a case at one restaurant and go to another restaurant and think everything's good, but there's a case at that restaurant. So with so much community spread, I recommend that people just assume everywhere they go in public, they're coming in contact with someone, hopefully not coming in contact, but people that are also out are potentially infected. You just gotta assume everybody could be infected. They're asymptomatic, but they're spreading it.
Thanks. One of the issues that has come up, in the last 20, 30 years, we've seen pretty significant emerging infections, HIV, AIDS. We don't talk about much, but as an emerging disease, but it is. Ebola, SARS, MERS, COVID-19. Jonathan, what should we learn from COVID-19? What could we or should we do better the next time? And I'll ask David the same question.
So I think if we learn anything, it's going to be how to mobilize rapidly up front to coordinate testing. I think that we were fairly good about from a scientific point of view, figuring out what's going to be a vaccine, which ones are we going to target for development. Those kind of things we did pretty well. But I think the testing was kind of a hot mess. And in great part because we just weren't used to doing that. It's not something that we should ever expect the health department to just all of a sudden be able to test 10,000 people a day. We just couldn't do it. And I think we were overwhelmed up front. We didn't have a great test up front, but it's a new virus. I can understand that. But if we can coordinate the testing with businesses and large bio groups that are good at this, so that we can mobilize it earlier and faster and more reliably, I think that would help. Because we had very, very long delays, and David could speak to this up front, where it would take 5, 7, 9 days to get the result back. That's really no good for trying to contain a virus. As infectious as this. If you know 9 days later, that's not very helpful because they've already gone out and spread it. So if I could change one thing, it would have been the rapidity and the reliability and the ability to handle testing. And David and I dealt so much with it up front, and it was very, very difficult.
Yeah, I will say that the World Health Organization back in 2017 put out a blueprint for research and development of the diseases they thought were most likely to cause potentially a pandemic. And a novel coronavirus was on that list as like number 4. So they already knew that we didn't have in 2017, we weren't ready for that. There's a lot of other things on that list. So, we know that we need to, there's like 10, 12 things on that list that, we need to be thinking about and preparing for. I would say the major thing that I hope we learn is that I think if you look at states or if you look at countries where public health, the media, and elected officials are all saying the same message to people about how best to protect themselves and others, I think those places have done the best in terms of the least amount of morbidity and mortality. So hopefully that'll kind of be the blueprint for going forward, where we have a unified message, that's science-based, and that everybody's saying the same thing so there's not confusion in the public about how best to protect themselves and other people.
There have been some questions that are specific to individuals with asthma or severe combined immune deficiency. Just to let the audience know, we decided in advance to just refer those questions to your healthcare provider. It's best if we don't try to answer specific questions related to health or specific individuals. But Jonathan, there was one question that came in about long haulers, people who appear to get COVID and not get better. What are your thoughts on that? What is that? What are the implications of that for control efforts?
So for the greater part, the vast majority of the people clear the virus within 1 to 2 weeks. And in terms of infectivity, the virus is gone, but that does not mean that they feel better. So there's a fair number of people that have been described now that have morbidities related to having the virus and they're still suffering. So for example, they might have a cardiovascular complication or a clotting issue or skin manifestations or fatigue or depression. We see this with not just this virus, but many viruses. The whole chronic fatigue syndrome concept is, we believe, in large part a post-infectious syndrome. And I think coronavirus will not be exempt from that. I think it will probably have a post-infectious syndrome in a certain number of the population as well. It doesn't mean they have the virus actively, doesn't mean the virus is causing disease right now, but it doesn't mean it didn't take a toll on them. We're seeing more and more of this described in the literature of these people with side effects that are longer lasting. So I think that that'll be more defined in the next 6 months to a year as we see more people with it. Very difficult to deal with those people. I feel for them because they just don't feel good. And we don't have good treatment modalities to help people with a post-infectious syndrome related to viruses.
Thank you. There have been a couple of questions that have come in about the possibility of people getting reinfected. We know there have been some reports of that. From a clinical standpoint, are they getting sick, or are they just getting documented reinfections, or could it be like dengue where you can actually get a worse second infection than the first one? What are we seeing there?
I think I can answer that, David, if you want. This is not like dengue. So dengue is a very unusual kind of virus with different serotypes that put you at risk for getting it again. Thus far, there's not a huge amount of mutation going in this virus compared to some things like, say, influenza. Part of the problem is how we measure immunity, and this is kind of my life in the laboratory, is how we measure immunity. We measure, for example, antibody. And antibodies in this disease in several studies seem to drop fairly quickly. You can see people with like a 25% drop in antibody by 2 or 3 months. And that's not that common in some of our viral infections, but I think in a coronavirus infection, I wouldn't be surprised if it's not that uncommon because it's more like a cold virus. And we can see that with certain cold viruses. Now, does that mean that person's not immune anymore? We don't know. There have been cases of people that were tested positive and then tested positive again and were sick. They weren't very sick, but they were sick. But it is unusual for us to see viruses where you get the exact same virus again and you don't handle it well. And I always remind people that neutralizing antibody, which we can measure in the blood, is just one measure of immunity. And we're not very good at looking at the cellular responses that control the virus. I can do that in my lab, but most people in the world can't do that. It's hard to do, to measure the cellular response to it. And I highly suspect that there are fairly durable cellular responses to the virus that are still present in those people. People that develop T cells against viruses, those T cells will develop memory, and they generally control viruses upon re-exposure. Even if they're exposed again, they tend not to get very ill, even if they do develop an infection again. So I'm not too concerned about it, at least right now, until I get more data. It's obviously not very common as yet. We haven't seen it that much. It's something to look for, but it would be atypical for most of the viral infections that I see. So that's just my, people may disagree with me, but that's my take, the immunologist in me's take.
Yeah, so I would say from a public health perspective, we basically say for 3 months after you're infected, if you get symptoms again, or even if you test positive again, we don't count you as a new case. But after 3 months, it's kind of a new ball game. So there is some data that shows for, we hope for at least 3 months people are immune. So, you would not have to quarantine if you're exposed within 3 months of when you've had an infection, things like that. But after 3 months, we have seen cases where people test positive again and get sick with coronavirus-like symptoms after 3 months, and pretty close after 3 months. So it's really still, we don't know, it's evolving. But from
and don't
public
be
health,
surprised if we change our recommendations. So don't be
from a
upset
public
when we
health
say, well, he said this. We just don't know. But
Yeah.
we may end up changing, and I'll blame it on David when we do.
Yeah, I think it's going to change, but we'll see.
Jonathan, a couple of questions came in on, you mentioned the vaccines not tested in the elderly, the folks that we need it most for. A couple of questions. Will it have been tested in children, breastfeeding women, other at-risk
So
populations?
some of the viruses are tested in younger kids, but I don't think any of them that the major ones were tested in real young kids. Like I want to say one was tested in 12 or 16 and up, but not young kids. And that's very, very common in clinical trials. They exclude people that are considered vulnerable populations, and children would be one of those. Prisoners would be one, people that are vulnerable. So I don't think we know. I think that they'll probably end up extrapolating it or doing the trials fairly quickly once we have the adult data. That's generally what's happened in the past. But I think right now we don't know. I think usually almost always pregnant women are excluded. So we don't know. The data on pregnancy with this particular virus right now is not horrendous like we've seen with other, like for example, with pandemic influenza where it was just terrible in pregnancy. It's clearly not, to that degree in pregnancy.
A quick question, David, for you. Can the virus be transmitted through cuts? through exposure?
Yeah, we don't typically think that it's bloodborne, so, would not be transmitted that way. For the most part, it's getting respiratory droplets from someone they cough in your face, and it gets in your eyes, your nose, or your mouth. Or potentially you could touch a surface and then touch your eyes, nose, or mouth, or eat without washing your hands. We don't think it's transmitted by food or really by blood effectively, no.
We're going to finish up a couple more questions. Healthcare workers would like to have access to rapid testing. Is there any local capacity for that or anticipated capacity?
Yeah, so the Binacs now, those, rapid point of care testing are being distributed. We're still trying to work out exactly which groups are going to get those, but, kind of first line people will be among those. Also school kids, probably, trying to get kids back to school to test them rapidly. But I think there's still some discussions about how exactly that's going to be distributed. Probably nursing homes, more so than hospitals, which have their own capacity to do rapid testing.
Yeah. So, of course, part of the issue with that is the sensitivity and specificity of the test. And is it sensitive enough? If you've got a negative, do you need to go ahead and confirm with the PCR test, which is the gold standard? I think ETSU Health has gone more with just developing its own capacity for doing the PCR assay, and where they'll be able to do fairly rapid same day kind of answer with the PCR test. They're kind of ramping that up as we speak, and we hope to have that available very, very soon. I think you'll hear more about that very soon, but that would be a same day PCR test.
Yeah, the problem with the rapid antigen test is that, if it's positive, it's pretty clear that you probably have it. But if it's negative, you still might have it. So, the negative result's not that good. And we recommend after a rapid antigen test, if it's negative, to probably get a PCR in most cases to confirm that it's negative.
One of the folks on the call said that their son is the PI on a vaccine trial being done at St. Jude's, so children are included in that trial. So just an update on that. Another question, is there any possibility that SARS-CoV-2 will enter a latent phase and then reappear in the same person, either?
No, it's not that kind of virus. In order for a virus to do that, it has to have a DNA intermediate, so it can't just be an RNA virus. It has to be able to somehow transform into DNA. The DNA gets intercalated or placed into our DNA, and then it becomes part of us. We see that with herpes virus. We see that with HIV. We see that with hepatitis B. But it doesn't go into a latent phase unless it can get into your DNA, and this virus is incapable of doing that. So it doesn't mean you can't get it again. We don't know yet, but it's not going to be one of those things where it comes out again after hiding for a long time.
Yeah, we do see people stay positive on their test though for multiple weeks after they're infected. So the virus, whether it's dead virus or whatever, but people, the PCR still can pick up the virus for multiple weeks, which is one of the reasons we don't recommend people require a negative test for someone to come back to work. As long as they're well and they've been in isolation for 10 days, they can go back to school and work.
Yeah, the PCR test is so sensitive. It will pick up even little pieces of dead virus that might be somewhere floating around. So as long as they're well, we let them go back to work.
Well, we have kept Dr. Moorman and Dr. Kursky beyond the agreed upon time, but I think that everyone would join me in thanking them for a really outstanding evening and addressing a lot of really, really important questions. I'm going to share my screen. Can you see that right now, the screen again?
Yes.
Okay. I just want to say that we do put out a weekly update on COVID-19. If anyone would like to be added to that mailing list, please contact Jan Stork at that email address, storkj@etsu.edu. I'd like to thank Jan and Dara Young for handling the Zoom recordings for all of this. Obviously, if you have any follow-up questions, please let me know. But finally, please join me in thanking Dr. Moorman and Dr. Kursky. This is really an outstanding evening. Thank you.